Hi, I'm thrilled that we can all be here today. Good morning. One of the things that I think we all believe makes Medicine X the best conference of its kind is that it involves patients, and today we're going to talk about that. All of us know that caregivers are crucially important anytime any of us are struggling with a medical issue. And today we're going to talk about family caregivers, that is, spouses and others in the family. In Inspire, there are about 400,000 members, patients and caregivers are a huge part of the conversation. Oftentimes, caregivers play a really important role in not only in supporting the patient, but also in making decisions. About a year ago, we did research with the Moffitt Cancer Center in Florida and Novartis in Boston. And this used it studied 300 stage 4 non-small cell lung cancer patients, half of whom were patients and half of whom were caregivers, and found a marked difference between the perceptions that patients had about their condition and the perceptions that caregivers had. And if we go to the next slide, it's really striking to see that if we look at the orange bars are the patient's perception of how fatigued and in pain and suffering they were, and the blue bars are the caregiver. And what we see is that consistently, the caregiver, that is the spouse typically, felt, observed that the patient was suffering more than he or she reported that he or she was. And it was really striking. And if we go to the next slide, we see that this continues, and it's fairly consistent across the board. And this was news. It was the largest study of its kind that had ever been done with lung cancer patients, and these were metastatic or late-stage lung cancer patients. And in fact, if we look finally at the willingness or the desire of the patients to participate in things to improve their state, new therapies and that kind of thing, here we see the reverse, that the patients were far more interested in participating than the caregivers were. And the belief at the time was that the caregivers were often worried that this would be exhausting or too challenging for the patients to do. So this difference in perception was really large and really striking, and it's led to sort of a whole lot of thoughts about why this might be and why it's important. One of the things we've come to believe is that it's important not only for the patient's caregivers to recognize, but also for physicians as they're meeting with and treating these patients. So I'm going to segue now to Maggie, who I'd like Maggie and Paul to tell the story. Maggie's a cancer patient, and Paul is her spouse, and they have a great story to tell.
Hi, I'm Maggie Heim, and today I'm playing the role of patient. Normally I'm a lawyer, and so is my husband, but he's the caretaker today. I picked this slide because my perception of the way people looked at me was that was more in line with what this says, is sort of the opposite of what the study Brian just described, that people think I am much healthier than I really am. And if they know I have cancer, they go, wow, you look great. And I think, I really don't feel good. But apparently, as we heard about this study, which was new to me, and I started talking to Paul about it, I found out that, in fact, that discrepancy between how he perceived things and how I perceived things was right on point. And I was underestimating, he was overestimating, or however you want to look at it. So let me tell you a little bit about my cancer story. I was struggling for almost a year trying to figure out why I felt really crappy. And I saw a bunch of doctors. I was fatigued. I had certain symptoms. Ovarian cancer is a rare disease. There's no screening test for it, and nobody was coming up with it as a possible explanation for why I wasn't feeling well. Eventually, I saw a gastroenterologist, and he figured it out and sent me to get a CT scan, and lo and behold, I had a huge tumor, so I was rushed into surgery. Well, not rushed, but a few weeks later I went into and had debulking surgery. As it turned out, I had ovarian cancer. It had spread quite a bit. It was staged at 3C, which is metastatic, but not to any area outside of the abdomen. And after I recovered from surgery, I had to go on a very tough course of chemotherapy. I had intraperitoneal injected into my abdomen. I had a port put into my abdomen cisplatin, which is a very, very tough chemotherapy, and Taxol, and I was supposed to do 6 rounds of this, and after 4 rounds, I stopped and switched the cisplatin to carboplatin. That's part of the story Paul will tell, and finished it up, and then a year later, I had a recurrence. At that point, I was interested in taking Doxil, but it turned out right at the point I had recurred, there was a major shortage. In fact, you were unable to get Doxil because the manufacturer, Benvenue Laboratories, had all sorts of problems in terms of their manufacturing status, and the FDA was about to shut them down, essentially, so they stopped making Doxil. So they couldn't distribute it to the patients anymore. And at that point, I started doing, in addition to my chemotherapy, I started doing some advocacy, and I set up a blog called Help Keep a Sister Alive, and to initially work on this drug shortage issue, which was affecting me very personally. And this is, you'll see on the slide, this is my current Facebook page. If you're interested, I post on there every day about different things involving ovarian cancer. And I also have a blog, which I write on less and less now, but there's a fair amount of information about drug shortages and other issues involving ovarian cancer there. And I also have a website, which I have now used to try to aggregate information for patients, particularly with ovarian cancer, to tell them how to find financial aid, how to find community services, particularly online, things like that, because there's a lot of information out there, but it's not very well organized, and that was my goal with Help Keep Sister Alive. Anyway, back to my medical history. I didn't get Doxil, no matter what we tried to do. I happened to be treated right in that 6-month period, 8-month period when it was completely unavailable in the market, so they gave me carboplatin by itself. I recurred 7 months later and then went into a clinical trial where I had problems eventually with the experimental drug, which is what I was getting, and they had to take me off of that, and I'm still on the other drug that they were giving with the experimental drug. I'm on Avastin now. My ovarian cancer appears to be stable. I haven't had a scan for a while. I had to go off the treatment for a while because in April I found out that I had breast cancer in addition to ovarian cancer. So we had to go find a whole set of new doctors for that, had a whole new set of treatment decisions, and I had surgery and other kinds of treatment. I'm now stable there as well, and I guess that's pretty much it. That's a long summary, but it's pretty much it. It's been 4 years, and we're steeped in the cancer treatment area, still doing it.
Could you share, Paul, can you recollect an experience where your perception of how Maggie was feeling was different than what hers was?
Yeah, we've been trying to go back over this, and one of the issues in this kind of situation, probably for most people, is that you're trying not to remember. Right? I mean,
sure.
You're trying to just get on with your life, and you make decisions and you move on with it, and you go. So we've had to do some archaeology. One of the things one of the areas that Maggie mentioned was when the decision came to how many treatments she should have in the beginning. I think her initial reaction was, and usually is, I'm going to tough this out, and I'm going to do whatever I need to do to be well and to give myself the best chance of survival for my grandkids, for myself, for everybody. And I remember being in that meeting with her doctor and being the one that would say, well, what are the percentages? I mean, how big a plus is this compared to how bad Maggie feels from this treatment? And I think in that conversation, we wound up collectively deciding, obviously Maggie is the one that decides, but it gave her permission, I think, in some way. That may not be the right word, but permission to not do everything that she could do, because it was a reasonable choice to do something different that would have less of an impact on her. And we had the same thing with the breast cancer, actually, even more graphically, I think, because Maggie's initial reaction was, well, I'll do mastectomy. That's the most I can do, so I'm just going to do it. And I don't think she questioned the doctor as vigorously about that because she had just gone there. And I was the one who was responsible for asking the doctor, well, so what are the percentages? What's the benefit of this? I mean, what in the overall scheme of her treatment? I mean, she's already dealing with ovarian cancer, and she's going to be dealing with that for the rest of her life, probably. What advantage is she going to get to a mastectomy and more vigorous treatment versus something else that might be, pretty close to what she'd get anyway? And I think that also, again, she decided to take a different tack probably than the one that she ordinarily did. And I think in our daily lives, we've thought of some examples of where the same kind of thing happens in terms of me reminding her about how bad she feels and that it's okay. Like we just went to Yellowstone Park about a month ago, and she's complaining every day at the end of the day. I'm just so tired. I shouldn't be tired. We should drive that extra 30 miles and see, some other geyser.
Or bison.
Or something, or another bison. And I would remind her, well, we've already seen 340 bison, and you're tired. You've just been going through chemotherapy for the last 4 years.
And radiation.
And radiation and everything else. And so, let's enjoy what we have and, just rest. Take care of yourself.
Sure. Anand, you are a geriatrician, and you often meet with couples, one of whom is a patient and one of whom is a caregiver. Are there messages in this for physicians, do you think?
Absolutely. So thank you, Maggie and Paul, for sharing your story. I know it can be difficult to sort of rehashing some of these things, and I think when you're going through the process, you're not deliberately thinking about what's always the right choice. You're just sort of acting. You're reacting. And as you said, like in most of my medical encounters, it's never just me and a patient. There's always a caregiver or family member involved. And in reflecting thinking about the story and us talking, I came to realize, sometimes as the clinician, we expect a lot out of the family member and the family in terms of interacting, and you're putting a lot of pressure on the caregiver sometimes too. And I think clinicians need to be aware of that to some extent. It's important.
Maggie and Paul, did you feel that your doctors were open to involving both of you in the conversation?
Yeah, I think the one thing about the doctors that I would think is that there are differences between the two, actually. But in one case, I think he had in mind a certain course of treatment that was the best, and so that was the default position. So unless we raised something to change that, that was what was going to happen. And I don't mean that, we love the doctor. He's a great doctor, and we have good relationship with him. But I think unless we had pressed that, I don't think the alternative would have been on the table as easily.
Right.
That's how, and that may not be true, but that was my impression of what was going on.
And were you doing the pressing more, you think, or?
I think so in that context, although Maggie's not a
Shy,
retiring person. She's fully participating in all of this.
Sure.
But there are times when I think I become the advocate, and then there are other times when I just shut up.
Right.
Usually she has a look.
I think that our gynecological oncologist, who's terrific, by the way, I think he was very receptive to cutting the treatment off. Cutting off the cisplatin. I was really sick, and I had no, but I was going to get through it. I was going to get through it because it was my best chance of maybe, not having a recurrence. In retrospect, of course, now that I've had a couple more rounds with this type of cancer, sure, why not? I don't think the extra 2 courses of cisplatin would have made a difference, and I'm glad I did it because I felt better almost immediately once we stopped it. So thanks, Paul.
Brian, sometimes that's where, in situations like that, where I'll even look at a caregiver, if I sort of feel a little ambivalent about how the patient's feeling, and maybe they're not as open about it, sometimes you'll sort of look at the caregiver and say, so how do you think this is going on?
Right.
Because you're sort of wanting that endorsement, and it's important as a clinician to involve the other person and get this second opinion.
Right.
Sometimes we know what the symptoms are.
Yeah.
Because I think that part of Maggie getting through all this is forgetting,
Right.
as much as she can. And so we may be in a meeting with the doctor, and the doctor will say, well, what's been happening? And she forgets something. And so I think one of the roles that we have is to, it's not exactly a perception issue, but it's to be the person that gets all the facts out.
Right. We see this across every condition you can imagine. Our prostate cancer community is 50% female, and it's not because they have prostate cancer, obviously. But those women who are the wives and daughters of men with prostate cancer, it's clear if you read what they're writing that there's an enormous amount of discussion about exactly what you're talking about, interactions with the physician, private conversations among themselves, and that these women are often drivers of treatment and decisions in treatment. And clearly, if you're the physician taking that into account, it's got to be part of the way you work with the couple. One of the questions that came out of this was why? Why do we see these huge differences in perception between patient and caregiver? And perhaps you could talk about this. One explanation is what we're looking at here.
Sure. So the other thing I do a bit of is research around decision-making and communication in clinical encounters. And this is a concept that is fairly common in psychology called hedonic adaptation. And it's really this science that says through experiments we realize that actually humans have certain set points for happiness or quality of life. And obviously, as the circumstances on your life change, if you're undergoing chemotherapy and there's lots of symptoms involved, I guarantee you the quality of life will change. But after a while, we adapt to stress, we adapt to changes in circumstances, and you kind of revert to whatever baseline quality of life you have within a range. It's not exact, and you do have day-to-day changes. And we see this really pretty consistently across humans.
So the idea is that the patient over time adapts because he or she is feeling the symptoms, but the caregiver does not. Is that?
That's right.
idea?
And then
Right.
if you look at the next slide, so not only that, but we actually make systematic errors. We as humans make systematic errors in making predictions about how we will feel in the future. And so we actually mispredict, and we also misremember. So this is a great study that was in the journal Health Psychology, where they took a set of patients who were in chronic dialysis and on the kidney transplant list, and they asked them, how do you feel now in terms of your quality of life, and how do you think you will feel after you have your kidney transplant? And then they followed them up, and after the patients had the kidney transplant, they asked them again, so how do you feel now, and what is your recollection of how you felt in the past? So what's really interesting is clearly they had a significant improvement in their quality of life, so there was some improvement from the first set to the second set of how you're feeling right now. But what's really interesting is that the patients in general predicted a much higher quality of life that they would have in the future than what they actually did end up having later on. And when they were recalling back in the past, they thought their quality of life was much worse than they actually said it was in the past. So we adapt, but then we also mispredict and misremember. So I think that probably is happening, especially when you have a loved one, and then there's all those emotions as well. And so you're thinking that they're going through something much worse than what they're going through at that moment in time, because they've already started adapting to it, and
Right.
you haven't gone through it yet, and you're not adapting as well.
Right. Is that something you can identify with, the sort of trusting or perceptions of your own memory throughout the experience?
Well, it's like childbirth.
Yeah.
You wouldn't do it a second time if you remembered what
Right,
it's like
okay.
the first time. You have no choice with cancer treatment, unfortunately.
Right. Good point.
That sounds right to me.
Yeah. Okay. On the next slide, this is a really interesting idea that Anand will talk about, which is this notion of family timeout period. Tell us what that is.
Yeah, this is a really interesting study where it really wasn't the original purpose of the study. I think this is a study of perceptions of patients who have stage 4 cancer, and it's about treatment discussions. And so the provider, the clinician, or the physician or the nurse would describe the chemotherapy or the palliative therapy for the patient. And what they found is that it wasn't just simply this very cognitive shared decision making. There's often a caregiver in the room, and the patient would often look at the caregiver and really want input and help decisions. And then at some point in time, either the clinician either turned around to type something in the computer or shuffle some papers or leave the room to come back. And there would always be this little family timeout, which is this short discussion between the family member and the caregiver about, how do you really feel? And so I thought that was pretty fascinating. And I'd say to the physicians and nurses out there that this is really something to maybe even be deliberate about. Create a moment to have a family timeout. Because you even want to maybe even encourage it. Say, talk about the things that are difficult. Because in reviewing what was actually coded in these transcripts, it wasn't a lot of in-depth stuff. It was more emotional and nudges and you're giving me that look, and that because the two people know each other really well, they felt like they knew what the look was. But I wonder sometimes you should actually describe what you're feeling, because you might not be expressing all the right feelings.
Right.
So create a deliberate family timeout and really encourage these difficult discussions.
I'm sure a lot of us have had that experience in the doctor's office with a family member, and you want to talk about something but feel a little awkward because the doctor's in the room. Can you remember instances like that where?
Well, I'm sure they happen.
Yeah.
I would never want my doctor to leave the room because I'd be afraid he wouldn't come back.
Okay.
So if you do leave the room, please tell your patients you're coming back. I'll just leave you alone for a minute. I'll be right back.
I think what happened with us was more that the family time came after the discussion with the doctor.
Right.
On the drive back home.
Right.
And sort of I think we trusted enough with both doctors that having them be part of that discussion was fine. And that, I think with a different doctor, that might not be the case. But I think with the two doctors that Maggie's dealt with, their demeanor and the relationship is good enough that we were able to have that discussion together. But after the discussion, we had to have another discussion on the way back, saying, well, now that we've had this discussion, do you feel okay with this?
Right.
Did we make the right decision?
Right.
Yeah.
Well, and I chose both of my surgeons, the gynecological oncologist and the breast surgeon, based on large part, in addition to extraordinary competence, bedside manner, and the ability to hear me and to talk to me and the willingness to talk to me. And I like to know a lot of things. I'm a curious person, and I ask a lot of questions. I do my own research. So I want a doctor who's interested in having that kind of relationship with me. So that's one of the reasons we have these two really great doctors that we can have this kind of conversation with. So at least that's my take on it.
No, you're fortunate to have found doctors that you really like and can talk to. It's important. I think we have time for some questions and some feedback with the audience. Does anyone have any thoughts along these lines, personal experiences to share, or questions or comments about what we've been talking about? Here we go.
Microphone's taller than I am. So I really appreciate you guys bringing up this subject. I'm Sarah Kaczorski, otherwise known as Afternoon Napper. Hey. I'm curious about your decision, Maggie, to take your husband to appointments. Because I know, and from my own experience and from talking to other patients, that there can be a desire to protect any caregivers, any family members from the immediate information. And I know that I will often choose to go by myself, particularly when I'm expecting bad news, because I would rather take that news in myself and digest it myself before regurgitating it or sharing it with anybody, even someone close to me. So how did that dynamic play into the actual appointments and your relationship with one another?
Well, first of all, Paul insisted on coming, and I would not, I'd not say no to that. I had a friend who, well, I think you came to the first appointment too, but I did have a friend who spent some time with me trying to help me get ready for the whole process of having cancer and so forth. And one of the things she said to me, take somebody with you to an appointment because you're not going to think of every question, you're not going to remember everything. If it's bad news, you're going to get overwhelmed. I told this to my cousin, who I recently found out has stage 4 cancer. So she does the same thing, and she's even gotten to the point where she's tape recording now the appointments. And I actually learned that from my best friend who had lung cancer and died several years ago. Said the same thing. She had to take people with her because she couldn't remember. So he's my caretaker, but he's also my note taker. And he thinks of things. He's not. I'm sitting there listening to this of, you're going to lose your hair. Oh my gosh, that hit me very hard. Foosh, what does he care? It doesn't. It goes over his head or off his head, so to speak. And he'll hear that, but he'll think of the 5 questions that I won't be able to ask because I've gotten too emotional about something, or I have chemo brain. I can't remember something. So I don't know. I'm not as protective of him, and I need his help, and I'm okay with that.
It's really interesting you say that, Maggie. We did our own study of shared decision making, and we found really tools that patients were using to do shared decision making. Very few of them were just about the patient themselves, but there was taking notes, bringing a second listener, audio recording, all these things, and it really involved the caregiver and family members as much. And so I really feel like now shared decision making is not just about the clinician and the patient, it's about the whole network around the patient. It has to be part of it.
When she was doing chemo, actually most of the time she was doing chemo.
Which has been pretty consistent for the last 4 years.
It's it was an hour drive pretty much to where we had to go. And she would often say, well, you don't have to go. I'll drive myself. But that's not what she really meant, because whenever I drove her, she would say, I'm really glad you drove me because this is tiring. And so, sometimes when she's trying to protect me, I don't need protection, and she needs the protection.
That's a good point. The other reason I liked him to drive me is that my blood pressure would go sky high driving in traffic in Los Angeles from where we lived to Cedars. And I'd get in there. They wouldn't give me the chemo if my blood pressure was high. So it was really great to be much more relaxed and, close my eyes to the people who are cutting us off and everything rather than having to deal with it.
Plus, she could play games on her iPad.
That's right.
The best part.
That's the best part.
Good. We have another question.
Check. Okay, thank you. I was diagnosed with type 1 diabetes my freshman year of college, so outside of the first 3 days in the hospital, it was me and my college roommates most of the time. Ultimately, my question is it worth talking with them about my diagnosis and my diabetes through their perspective, even though it was 10 years ago, if maybe to offer some kind of sense of closure for them, because we never really talked about my diabetes, my diagnosis, anything like that. I took care of myself. I'm here today, but I'm curious if you think that there might be any kind of value maybe for them, even if we never really talked about it at the time.
For them,
for my college roommates, because
right.
While they weren't necessarily my caregivers, I was living with them, and I think that they were aware of the fact that I had diabetes, and while it was up to me to do everything myself,
Sure.
I never really considered what was going on in the back of their heads, even as they were going through their college experience too. All of a sudden, there's potentially an additional burden of knowing that I have something that's out of the norm, I suppose.
Yeah. What's clear in everything we read is that the people around you, your college roommates are sort of your family when you're in college, that it's intense for them as well. In ways that maybe are not appreciated oftentimes. So my gut would say yes, but
I think you'd find that it was probably a formative experience, not in the same way as it was for you, but it probably was a formative experience for them as well. And each one of them has probably reacted differently to it. And I think you'd have to sort of feel that out with each of them. But it maybe for some of them it might make sense to do something like that.
Thank you.
Thank you.
Hi, thank you all for sharing your experience and expertise. I'm Lena Nguyen. I'm a physician, and I also was the caregiver to my mother who passed away from cancer a few years ago, and so I just want to relate to your story and thank you for sharing. But also wanted to ask you, one of the questions that I get asked a lot now as a physician and patient advocate is, how can you find a good doctor? And it's something that I struggled a lot with my mother. I remember we were living in Los Angeles at the time as well. We would go to various oncologist offices, and they would look at two Asian women and say, "Do you speak English?" I mean, that was an experience that we had fairly often in LA of all places. And I know the things that we would be looking for in a good doctor, but especially when you're facing a condition like cancer, where you want someone that you really relate with and that you can partner with, how do you go about finding a doctor?
That's a great question, and related to that is if you see a doctor and it's not a great doctor, how do you switch? I know that this switching doctors creates a lot of stress for patients. Their feelings that it's okay or not okay to do that. But that's a wonderful question. Any thoughts from you and maybe from anyone else?
Well, it's very interesting. For ovarian cancer, it's most women, there was a study that was actually reported in the New York Times, and I can't remember who actually did the study, but it came out about 6 months ago. Most women go to their internal medicine doctor or their gynecologist, and you really need to go to a gynecological oncologist. It really it is a specialization, and it requires that. Now, I did the same thing. I called up my gynecologist, whom I also love, and she said, "I can't deal with this for you. You need to see a gynecological oncologist. There's a practice at Cedars-Sinai that I think very highly of." Now, independently, I talked to 2 other doctors, and they both recommended the same practice. I figured this is pretty good. So, interestingly, though, one of them recommended one doctor who everyone else told me did not have a good bedside manner. The other one recommended younger doctors who I believe have been trained more in this. I think that the training in medical school has changed. And it turned out that I went and met with the younger doctor and loved him, because I loved his bedside manner. And I felt safe with him. And I knew I was going to be able to get good information out of him. Now, lawyers tend to this might be a little segue. We like to kind of sketch things out and see, if A, then B, if C, then D. He doesn't do that. He kind of deals and he's very linear. Oh, well, we'll do this first, we'll see how it works, and then we'll do that. I'd have my whole treatment for the rest of my life planned out by now if someone would talk to me about it. But that's a minor problem compared to some of the things I read where you don't have the people who have the expertise. So to answer your question, I just talk to a lot of doctors to get their expertise. And to your point, I think every one of our doctors is Asian descent. So they would love you. They would know you speak English.
Thank you.
Hello. My Twitter handle is Kathy Kastner, and I often wonder about managing the community around you, not just, having to take care, as Sarah has asked, about husband and wife or whomever coming to a doctor's appointment, but I know I go to an exercise class, and every single one of my exercise class coffee clatch people afterwards has an opinion about my treatment. Should I share it with them? And I wonder if you have had experience having to, as it were, manage your community outside of your immediate family.
Good question. There's a decision there, right, about whether you want to share it at all, right?
Well, I found I was oversharing in the beginning with people. And one of my colleagues pulled me aside and said, "You got to stop that. When people ask you how you're feeling, don't tell them." So I came up with the okay. I'd say, "How are you feeling?" "Okay." But I was telling people too much, and people's reaction, I knew it right away, was like, "Oh my God, you've got a life-threatening cancer." It's like, whoa, I better stop this. I don't want that going on. So I've kind of learned from interacting with people in a way how to manage it. Plus I had a good friend who said to me, "Cut it out. You're really freaking people out." And I think that was helpful too.
One of our problems in the very beginning was that we just had so many people making chicken soup.
Ugh. Or polenta,
It's like
man.
people wanted, their reaction was, "Well, we'll get food for you."
Yeah.
And Maggie, the last thing in the world she wanted
Yeah,
was food at that point.
that is true.
So we had to manage the community just by saying, you can really be supportive without without giving us all this food that we're going to
That's
throw
right.
away, give to a food bank.
Thanks. I think that often gets left out of the sort of the care continuum, that you have to expend energy, you have to manage your community, expend energy doing that. So thanks.
You know, we see the flip side of that sometimes too, which is that patients who clam up, keep it inside, don't want to share anything at all, and are kind of being urged to share some. Is that just individual coping?
Yeah, I mean, I think that's a very individual answer. You know, it's what you're comfortable with, and sometimes it's too much information, sometimes it's too little. I mean, I would say what we've learned from decision psychology is most decisions that we make that we have confidence in have a lot of emotional component to them and are socially constructed. So you've got to identify who it is that, for you, who is that brings meaning to your life and your decisions, and I would say try to involve them, because you're going to make a better decision if you get consensus around the people who you sort of define as who's
Right,
important to you.
Right. You know, a related decision is that it's so easy today for any of us to research our medical condition in a way that 20 years ago was very difficult without university libraries. And we've done some other studies where we found that a lot of patients, a subset of patients want to feel that they are involved in the decision, that when they make decisions with their doctor, they want to feel that they are part of the decision. And so the notion of shared decisions there, in your experience, is that something that has really changed over the past 10 years, the time when people have been able to access this information? Or are they just empowered with more tools?
I think it's both of those. I do think there's a generational shift. That's pretty consistent in the literature, that the younger, and I think it's not just because they're younger in age chronologically, but I think the younger generations tend to have a different view of doctor-patient encounters than let's say the greatest generation, the current generation. That's a bit older.
And it seems that some doctors are more open to it than others.
Yeah, and I think that's changing too.
Yeah.
Over time.
Good.
I think we're now the greatest generation, right, Paul?
I don't know.
Any other questions? We have one.
Lee Fleischer, I'm a physician interested in shared decision making. And thank you for sharing. My question's really around regret, and in the material needed to present to the patient, and we have very sophisticated patients here, to help make sure, you actually made a comment at one point to say, would you ever do it again? And the question is for both the patient and the caregiver, what kind of material do you think we need to present that they could understand the consequences of their decisions for both of them? Because I'm very concerned about, as attorneys, you may understand numbers, but people hang on to see numbers differently. So that's my question.
Well, one of the best things I think our doctor did for us in the very beginning was he said, don't go on the internet and look at the numbers of survival rate. I hope this speaks to your question, but that was a huge thing for us because we were pretty freaked out about, the stats and such. And we didn't do that. And I still go on, but I know things have changed, and I kind of, that's something I'm glad we did. I don't know if there's anything you would do differently.
You're a little bit unusual as a patient because you taught statistics.
Okay.
Oh, yeah.
And so, for someone who taught statistics, one of my big memories of your beginning treatment was one of the nurses came in the first chemo and said, now, I don't want you to be worried. I want you to explain the statistics to you. And Maggie sort of looked at her and said, no, I don't think you need to do that.
Not the typical patient.
Yeah, no.
What are your thoughts about that?
I mean, this is definitely an area that we don't know as much about, and there, there's some work right now from decision psychology again that says a lot of good decisions are framed around two things. One is gist, or what's the bottom line meaning of so if you offer a treatment, what's the bottom line meaning of that? I don't need to go into every last detail about it, but then everyone does want some degree of details, and what you recall, that representation or that number or that fact, it does vary then. It varies by your sophistication with numbers, your sophistication with facts, and then a population of people react very differently. So some people, you know, that number about mortality is just, that's what sticks with them, you know, or that feeling about what this side effect is, or it's what sticks out in people's head, which number sticks out, and what stays the same. It's really different by each person.
Right.
Our doctors, I think, were terrific at explaining the significance of numbers in words. I mean, I think Maggie understands the statistics. I don't. And I could understand the way they described it in a way that made sense to me in terms of what the real-life consequences were. And so being able to explain, you know, what the differences are between having a mastectomy or a lumpectomy in common sense terms is a really important thing.
So he's just describing that
There you go.
exactly. So
Right.
there's a couple of facts that you took, and then you made a bottom line meaning out of those couple of facts.
I think we're out of time, unfortunately, but this has been a wonderful discussion, and I just want to thank Maggie and Paul and Anand for being here, and thank all of you for your questions. So.
Thank you, Brian.